Doctor, everyone has entered.
Apa?
Semua dah masuk.
Semua dah ada? Okay, start. Siapa? Ahmad Afifi. Topik apa?
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. So all of you can hear me?
Yes.
Yes.
Okay, so my name is Hafifi. So 131616193. So insyaAllah today I will talk about the chronic diarrhea in children. So if there is any problem with my voice, let me know. So next slide. Okay, firstly, this is my outline. Firstly, I will talk about the introduction, a little bit about the diarrhea, chronic diarrhea, and then clinical approach, which is include history or also examination, and then investigation, principle of management, also common cases of the chronic diarrhea. So I will talk today about the chronic diarrhea in children. So children, here is I mean the start from the toddlers up to children, not include adolescent. So for chronic diarrhea, the definition based on Nelson textbook, the definition of chronic diarrhea is stool volume of more than 10 grams per kilo per day. This is for toddlers and infants. But for the older children, more than 200 grams. That lasts more than 14 days. 14 days. So the cut-off here is 14 days. So if it's less than that, we call it the acute diarrhea or AGE. GE. So this is about the chronic diarrhea. So means more than 14 days. So if imagine the children have 10 kilogram. So if the children have stool more than 100 gram. So 100 gram means she or he may have the chronic diarrhea that consider chronic diarrhea. And based on other sources, and the chronic diarrhea defined as an increase in fluidity, volume, and frequency of stool relative to usual habit. So there are three components: fluidity, volume, and also frequency. So and also based on WHO, the diarrhea defined as more than three loose stool per day. So also applicable. Sorry?
More than three.
Three or more. Sorry. Three or more. So that is according to WHO. So mind you that definition, just a definition of the diarrhea. Certain sources state that the chronic diarrhea is more than 4 weeks. And for more than 2 weeks, just persistent, considered persistent diarrhea. But based on Nelson, I took from Nelson, so it's considered more than 2 weeks for chronic diarrhea. Certain books say it is more than 4 weeks. So just to highlight that. And okay, let's proceed. So that's about the definition. So the chronic diarrhea is more than 14 days. So I bet all of you quite familiar with this 4 mechanism of diarrhea. So it also applicable to the acute diarrhea or also chronic diarrhea. So basically the mechanism of diarrhea have 4. There are more, but this is the main mechanism of diarrhea. First one is osmotic diarrhea. Second is secretory, and then inflammatory, and also fatty diarrhea. The other one also should include mortality disorder. So the main is 4, but you can plus 1. Mortality disorder 1. I should include one more. There are more mechanisms, but this is the main mechanism of the diarrhea. And some of the disease or problem is overlap between this mechanism. Okay, next. Okay, let's take a look about the osmotic diarrhea. So osmotic diarrhea, by the name osmotic, so which means that there are non-absorbable nutrient in the lumen. So the food or any substrate that in the lumen cannot be absorbed in the intestine. So this substrate or food lead to osmotic pool, or lead to water is pulled from the our body, so into the lumen. So that's why the patient will have the diarrhea, because that substrate in the lumen, this substrate or food will withdraw or pull water from the body. So you can see at the picture at the right side. So the causes is like I mentioned before, injection of poorly absorbed substrate, and also by malabsorption. For example, the causes is the common one is functional diarrhea, or we call it toddlers diarrhea. I will talk a little bit more about this after this. And also magnesium injection, phosphate, and also sulfate. And last but not least is lactose intolerance, quite common. Okay, that's about the osmotic diarrhea. So next. Okay, apart from the osmotic diarrhea, we have secretory diarrhea. So you have to differentiate between these two. So secretory diarrhea, by the name is secretory. So something is secret from our body, not due to the osmotic pool, but it is due to the something that trigger our body to secrete the water or electrolyte. So active electrolyte and water flux towards the lumen. It is, for example, the toxin, enterotoxin, or any bacterial toxin. That toxin will cause our body to secrete more water or electrolyte into the lumen. So that cause diarrhea. Okay. So the causes is bacterial toxin, laxative, hormonal, and also drugs, some drugs. Okay, that's about the secretory. So you must differentiate between these two, secretory and also osmotic. Okay, so the other two is inflammatory diarrhea and also fatty diarrhea. Inflammatory, inflammation caused by inflammation, and this inflammation cause damage to the intestine epithelium specifically. So for example, the causes is IBD, quite common, and celiac disease, not common, but it should include because it is important causes. Infectious disease, radiation colitis, and also neoplasm. And the fourth one is fatty diarrhea. So fatty means steatorrhea. So for example, the causes is maldigestion caused by the pancreatic insufficiency in cystic fibrosis, and also malabsorptive syndrome. So the digestion problem and also absorption problem. So the causes is short bowel syndrome, also celiac disease. Okay, these are the four main mechanisms. So first one, osmotic, secretory, inflammatory, and also fatty. And plus with mortality disorder. Mortality disorder, I should mention here, but okay, mortality disorder is, for example, in IBS, irritable bowel syndrome. Sorry. Okay. Okay, next. Let's proceed to the. Okay, these are the summary lah. You can read. So okay, so like osmotic defect I mentioned before. Look at the bottom one, the others. So osmotic diarrhea will usually stop with fasting, because we stop ingest the substrate of food. So the problem or diarrhea will stop. As compared to the secretory, it will persist even after fasting. And usually inflammatory will have the blood or mucus and white blood cell in the stool. So that's the one of the difference between these two, and you can differentiate between these two. There are more, but you can should include this one. So you can look this table later. Okay, next.
Nanti ya. Pergi
Okay.
balik. Pergi balik. Osmotic, okay. Stu. Okay.
Okay. So let's suppose that's about the introduction, classification, and also definition of the chronic diarrhea. So how to approach the chronic diarrhea? So as usual, we start with history first. History, what we want to ask the patient or parents of the child. So firstly, we must acquire the timing of the diarrhea or onset. So when the diarrhea is the onset, so if neonatal onset might suggestive of congenital diarrhea, abrupt onset, infectious diarrhea, so in bacteria, but usually bacteria and also viral cause acute, just acute. And then gradual onset of my diarrhea, for example, is functional diarrhea. Functional diarrhea is toddlers diarrhea. The other name is toddlers diarrhea. And then after gluten contained food, for example, in celiac disease, so the food sensitive or this triggered by gluten, celiac disease. So diarrhea with temporal relationship to eating. So this you must ask in the history. Is that the diarrhea, is that diarrhea caused by the food ingestion, triggered by food ingestion, or some specific foods? And then after we ask about the onset, we also need to know about the stool characteristic. Ask about the stool characteristic. So we must ask the parent. So is there any blood in the stool? The color of the blood, color of the stool. Is there any light stain color? So this is suggestive of celiac disease. So if the stools is become looser as the day progress, so it must be suggestive of functional diarrhea. So functional diarrhea is quite important. So I will talk more after this about the functional diarrhea. So this onset and also characteristic of the stool, you must ask in the history. So next. Okay, apart from that, we must ask about the associated symptom. So for example, abdominal pain. So abdominal pain might suggestive of IBD or IBS. And failure to thrive, and also weight loss, history of weight loss, history of recurrent infection, suggestive of cystic fibrosis, which is not common in Malaysia. Excessive flatus, for example, in carbohydrate malabsorption. Okay, this associated symptom. There are more other symptom, but this is the basic one. Okay, for medical history, you must ask about the HIV, immunoglobulin deficiency, cystic fibrosis, celiac disease, hyperthyroid, IBD. So hyperthyroid, you know the hyperthyroid can cause diarrhea. So you must ask the any history of the hyperthyroid also. So any therapeutic such as drugs and also radiation. So this can cause diarrhea also. Okay, next. Okay. Apart from the medical history, we must ask about the nutritional history, which is quite important. So breastfeeding it is quite exclusive, or because exclusive breastfeeding may protective against the infection. And the formula feeding, hygiene, about the hygiene, intake of sugar-free food, excessive juice. So you must ask this question. About the family history, you must ask about the family history of IBD and also celiac disease. But the negative family history does not rule out the diagnosis. So you must remember this. So also last but not least is social history. You must ask about the housing condition, hygiene, water supply, okay or not. Also sewage disposal. Okay, that's about the history. So you must ask this history because usually the chronic diarrhea is not easy to diagnose. You must you must refer to specialist. It's not like the AGE, not the acute one. So you must gain a complete history to proceed with the relevant investigation after then. Okay, then next. Okay, for apart from the history, you must do a physical examination. Okay, firstly, you must plot the growth chart of the children. Any problem with the growth, failure to thrive. Also, you must look at the hydration status. So usually chronic, usually acute is important, but also chronic important to look at the hydration status of the patient. Also nutritional status of the patient, vital signs, any fever, hypotension, tachycardia. So this is suggestive of the dehydration or any infection, and also extra intestinal sign. For example, in the IBD, erythema nodosum, like in the picture, pyoderma gangrenosum. So this is suggestive of IBD. Apart from the general examination, we must go to the specific examination, which is abdomen. Abdominal distension might suggestive of any malabsorption because there are more gas in the our intestine or our stomach, so you be distended. Tenderness might suggestive of inflammation, and fecal mass, constipation, bowel mass, also IBD. Also must do the perianal examination. Apart from the PR, also we must look at the perianal. So perianal to look for any fissure, any skin tag. But if the patient have any fissure, you must don't do PR in the patient. Also we can look at the any blood in the stool. Okay, next. So this is the how to assess hydration status. So I think you are familiar with this. So this is important. How to assess the hydration status. For example, sunken fontanelle, consciousness, mucous membrane, skin tear, and some more. You can look later. Okay, next. Okay, after the history and also the physical examination, you must do the investigation, relevant investigation. Okay, for I should include the algorithm, but the algorithm is quite complex, and I think this is a simpler one. The algorithm, you can look at the protocol, page 43436. For protocol latest one is 436. So you can look the algorithm. There are 3 algorithms for the chronic diarrhea. So just for principle of investigation or relevant investigation. So usually we start with the full blood count. Full blood count to look at anemia, HB, anemia in IBD, any white cell count is in leukocytosis, suggestive of infection. Also thrombocytosis might suggestive of the IBD. Classical, I think it is due to the inflammation, or we call it reactive thrombocytosis. So apart from the FBC, we must do the liver function test to look for any hypoalbuminemia. Also in the IBD. IBD here is I mentioned. Crohn's disease and also ulcerative colitis. ESR for chronic inflammation. Urea electrolyte to assess the dehydration status. Okay, so after that, the most important one is okay, next. Next. So the most important investigation is stool test, stool examination. So what we want to look in the stool. So firstly, we look at do the culture for bacteria. Second is virus study, Clostridium toxin, CD toxin, microscopy for parasite and also parasitic ova and also cyst. Osmolarity, you must remember this, osmolarity. So apart from culture and also microscopy, you must do osmolarity of the stool and reducing substance. And is there any reducing substance? Fat globule, elastase, calprotectin, and also lactoferrin. So calprotectin and also lactoferrin is like the ESR or CRP in the blood, but it is in the stool. So calprotectin and lactoferrin, it is inflammatory markers in the stool. So if the increase in the calprotectin or lactoferrin in the stool, it might suggestive of that inflammation in our intestine. For example, in IBD, I think these are the new one, calprotectin also lactoferrin. Okay, so osmotic gap. So why we must do the osmolarity? We want to look at the osmotic gap. Osmotic gap is to differentiate between the osmotic and also secretory diarrhea. Apart from the symptom or clinical, we also can confirm the difference between secretory and also osmotic by doing the osmotic gap or calculating the osmotic gap. So what is osmotic gap? I will explain later. So also if any reducing substance such as glucose, fructose present suggestive of carbohydrate malabsorption. So that's important one. Stool test. You must do the stool test in the chronic diarrhea. For celiac serology, if we suspect the celiac disease, we must do the IgA antibodies. Antibodies against the tissue transglutaminase, IgA TTG, for celiac serology, celiac disease. We must do also colonoscopy to look at any lesion in the IBD, barium follow through to look any involvement of the small bowel lesion, any lesion at the intestine. Okay, these are the basic investigation you must do in the chronic diarrhea. Okay, next. Okay, this about the osmotic gap. I think you are also familiar with this one. Osmotic gap, how to calculate osmotic gap? 290 minus 2 times potassium plus with sodium in the stool. So this is the formula for calculating the osmotic gap. So the how to differentiate? Usually the secretory diarrhea, the osmotic gap is less than 50. The cutoff is secretory is less than 50. And for osmotic usually is high, more than 125. This is based on certain most sources lah. Other sources might say more than 100, might than 75. I'm not sure which one is the cutoff for the osmotic one. But usually, just remember the osmotic is more than 100 and secretory is less than 50. Between that, it might be overlap between these two. As I mentioned before, the disease can overlap between the mechanism. Also, we look at the pH more than 6 for secretory and less than 6 for osmotic. So remember lah, osmotic more than 100, secretory less than 50 for osmotic gap. Okay, next. Okay, so for principle of management, this is just principle management. So if we suspect the certain problem, we can go manage specifically the disease. So this is the principle. So initial resuscitation, we must correct if there are any fluid and also electrolyte abnormalities, hypoglycemia, also prevent the hypothermia if there is any problem with that. So identify and also treat underlying causes, for example, by using the antibiotic, also antiparasitic, and we must refer to specialists if necessary. But usually chronic diarrhea will need referral. So next one is apart from resuscitation, we must do nutritional assessment of and also rehabilitation or rehab. So we must identify a potential harmful nutrient and also to avoid any food or any nutrient that cause the diarrhea. And for example, in lactose intolerance, you must start with lactose-free diet. And if the diarrhea persists, we must consider bowel rest and also parenteral nutrition and gradual of interaction of feeding. This is the for lactose intolerance. For functional diarrhea, for toddlers diarrhea, for F principle, reduce fructose and also fluid, increase fat and also fiber. Okay, we must consider enteral feeding. For example, NG tube, gastrostomy, or parenteral nutrition if the oral one is failed. And we must consider nutrient and also vitamin supplementation. For example, iron and also vitamin A if the patient having a deficient. Okay, this is the principle of management. Okay, so next. Okay, for pharmacological therapy, we might consider an antibiotic if only indicated. For example, in bacterial causes, immunosuppression in IBD and also autoimmune, anti-secretory agent, for example, racecadotril, and also adsorbent, smecta. So smecta is quite commonly used for the diarrhea. For adsorbent. Adsorbent means this drugs will bind to the toxin and will help to the problem. Will eliminate the causes. Adsorbent. So that's among the pharmacological therapy. Okay. Okay. Next. Okay, so let's look a little bit about the common causes of the chronic diarrhea incident. There are more causes, but I just include 3. Toddlers diarrhea, celiac disease, and also IBD. But celiac disease, I think it's not common,
Overdue your
but
time.
it's important.
Hello?
Sorry?
Cepat. You dah overdue your time dah. You dah
okay.
10 minit dah.
Okay. Okay. So let's take a look fastly. Toddlers diarrhea is also known as functional diarrhea. It is a commonest cause of diarrhea in children less than 4 years old, toddlers. So that's why the name is toddlers. And usually painless passage of the 4 and more large stool, and absence and nighttime defecation, no failure to thrive, resolve spontaneously by school age. So it's benign, and the causes is thought due to the excessive intake of fluid and also non-absorbable carbohydrate. The management usually dietary modification, so reduce the consumption of the juice consumption. Next. Okay, so for celiac disease is the gluten-sensitive enteropathy. It is caused by the immune-mediated inflammatory disease of the small intestine. This inflammation cause injury to the mucosa of small intestine and due to the ingestion of the gluten. So, for example, in wheat and also barley and also oat ingestion. So this cause inflammation. This inflammation cause injury to the mucosa of the intestine. So usually symptom begins at the age of the 6 months. 6 months. Presentation usually diarrhea, vomiting, failure to thrive. So there are failure to thrive usually in celiac disease. It's quite severe. Irritable, decreased appetite, flatulence, and also distended abdomen. Okay, next. Okay, for investigation, we must look at the anemia, hypoproteinemia. For investigation, like I mentioned before, TTG and TTG. And also biopsy to look any villus atrophy in the biopsy. For treatment, simple is just strict gluten-free diet. Just take other food. Next. Okay, so about the IBD. So IBD, I think you are familiar with this one. IBD, so comprised of the UC and also CD. Crohn's disease usually come with the abdominal pain, chronic abdominal pain, inflammatory, increased inflammatory marker, increased concentration of calprotectin, also lactoferrin. And usually 25% of the patient present before the 20 years of age, young age. Have a family history of IBD, and usually may be associated with extra intestinal manifestation. For example, in erythema nodosum, gangrenosum, and also uveitis, and also arthritis. There are more manifestation. You can look later. Okay, next. So this is the for Crohn's disease. I think you can read later, specific for the Crohn's disease. Okay, next. Ulcerative colitis also. So next. So basically Crohn's disease also ulcerative colitis. Next. The usually the next. The difference is the lesion. Usually Crohn's disease have skip lesion. The ulcerative colitis usually continuous. So it's continuous. Skip lesion means you can look at the picture. So that's the skip lesion. And also transmural involvement. Transmural means all layer. And the colitis just the epithelial or the superficial. So that's the main pathological difference between these two. Next. Okay, you can look at the picture later. Next. And okay, this is the difference.
Okay.
Next. Okay, that last one is the management. So management is about the same between these two. Prednisolone, sulfasalazine, immunomodulators such as azathioprine, and consider colectomy if the severe disease. For Crohn's disease, I have nutritional therapy. So give the protein modular feed. And we give also the prednisolone, sulfasalazine, and azathioprine. So this is the management for these two. Okay, I think that's all about the chronic diarrhea. You can look further. Okay, so any question? Okay, thank you.
Abdullah Ramli ya?
Yes. Abdullah bin Ramli. Abdullah bin Ramli.
Okay.
Alright. Okay, Assalamualaikum warahmatullahi wabarakatuh. So, I'm going to continue with the
Rasa sekarang mana banyak? Chronic diarrhea ke chronic constipation?
Sorry, Doctor?
Mana banyak? Chronic diarrhea ke chronic constipation?
Constipation.
Constipation lagi banyak sekarang.
So, it's more common to have chronic constipation case. Okay, that's right. Okay, so I'm going to talk a bit about chronic constipations. So the definition from the Journal of Pediatrics, the definition it is defined as the delay or difficulty in defecations present for more than 1 month, and it is significant enough to cause distress in patients. Okay, next. So over here I include this stool chart which can act as a guide for you to ask and for the patient to describe the stools. in which is constipation, what kind is normal. So I hope you can remember this stool chart. Okay, next. So about chronic constipation, the causes of the etiologies, it can be due to functional constipations, or it can be due to organic causes. It can be due to anatomical, intestinal nerve, or muscle abnormalities, such as Hirschsprung's disease.
Aku dengar sangat lah.
Hello?
Semula-semula.
Okay, so I'm talking about the etiology. So it can be due to the off-functional constipations, or it can be
Definition dulu, go to definition. Balik semula.
okay. So this is the definitions from Nelson textbooks. So it is a delay or difficulty in defecations present for more than 1 month, and it is significant enough to cause distress in patients. Okay, next. So over here I attached the Bristol stool charts in which I hope that you can add as a guidance to describe the kind of stool that we are discussing. Okay, next slide. So these are the etiology that I've been talking about. It can be due to functional constipation, or it can be due to organic causes. It can be from including anatomical causes, intestinal nerve, or muscle abnormalities such as Hirschsprung disease. It can be due to drugs, metabolic disorder, and intestinal disorder. Okay, I include all the possible diagnoses at the next slide. Proceed to the next slide. So basically, this is the table that compile the common cause of constipation.
Bila you all kan, bila you all
Yes.
dah nak tulis buat macam ni, you tengok siapa nak baca? History, examination, laboratory.
I'll be selecting a few from this list.
Ya, tapi sebelum tu you have to go all together. You got to disease terus. Your clinic, you kena present term of clinic. Faham? Apa history dulu macam orang tadi, dia present general dahulu, baru dia go for disease.
So, this is my approach. Approach is
Orang boleh baca tau. Why you want to put something and nobody can read?
okay.
Malas nak tulis balik. Tengok ke depan. Forward. Ke depan, ke belakang. Nah, pakai start yang ni.
Oh, okay. So, okay, I'm going to start with the functional constipations. So, I think it's based on the Rome 4 diagnostic criteria, which is it can be developed in infants and toddlers up to 4 years. 1 month, which of the two of the following, which includes 2 or less defecation weekly, history of excessive stool retention, history of hard painful bowel movement, history of large diameter stool, presence of large fecal mass in rectum, or 1 or more episodes of incontinence after toiletry, and history of large diameter stool that may clog the toilet. Okay, and in children of 4 years old children with more than 1 week of 2 or more of the following, or 1 month of 1 of the following, which includes as listed 2 or less defecation in toilet per week, 1 or more episodes of fecal incontinence per week, history of retentive posturing, history of painful or hard bowel movement, then presence of large fecal mass in rectum, history of large diameter stool that may clog the toilet, and symptoms that cannot be explained by another medical condition. So this is basically the Rome 4 diagnostic criteria in which they can help us to identify functional constipations. So in the next slide, so this one I'm going to briefly explain about the pathophysiology of functional constipations. So okay, so the stresses functional constipation, it could be due to initiation or too early toilet training, daycare, sending the child to daycare, or dietary changes. So this is the stressor that might induce functional constipation. So the child, it is usually will try to withhold the stool, which in return will make the stool is harder and larger, difficult to pass. And from this fact, it will cause a painful defecation for the child. So to avoid this pain, the child will voluntarily withhold their feces. And with this act, it will cause more painful if the child try to defecate. So the child will tend to lessen defecation. So this will cause lessen defecation reflex and peristalsis, and thus uh, contribute more to withholding of the stool. So this is a kind of vicious cycle that a child is having from their functional constipations. So I hope you guys can get the brief idea about the pathophysiology of functional constipation. So the next slide. Okay. So the clinical features of functional constipation, that we can see the child has a retentive position, as you can see from the picture I provided. So the child is actually try to withhold the stool when they are doing posture like this. And then another clinical feature is that there could be a history of blood in the stool with passage of large bowel movement. And then encopresis. What is encopresis? Encopresis is actually a voluntary or involuntary passage of feces into inappropriate places. Okay, the place is not inappropriate. At least once a month for 3 consecutive months, once the developmental age of 4 years has been reached. It means child passed to not appropriately. And then soiling of the underwear, often misinterpreted as diarrhea by parents. So this is the clinical features that we have to take note that might help us in the functional constipations. Okay, next slide. So this is a few others example of retentive position that I include. Okay, next one. So about so these functional constipations, the treatment, it involves both the patient and the caregiver educations. So we need to educate them about this kind of functional constipation, and we outlay the kind of management that is available for them. And then the next one is relief of infection, in which we can spread the child with enema to relieve the stool infection. And then we can also use stool softener. Apart from that, regular toilet training is an important point, is an important part of how we can assist the child who have functional constipation. Usually we can advocate the parents to have a regular toilet training that, for example, patient has postprandial toilet sitting, in which they have their own habits of evacuating their bowels. And the next, last but not least, is balanced diet, in which the child will include all the necessary nutrition, which include adequate fiber, adequate proteins, carbs, and adequate fluid. So these are the general or the treatment that we can give for a patient with functional constipations. And bear in mind also, the caregiver should be instructed not to respond to soiling with shameful or punitive remarks, because children are likely to become angry. They could be ashamed and resistant to any intervention. So parents should be actively encourage their child with rewards or adherence to a healthy bowel regimen, and to avoid struggles. Okay. All right. Next one. So this is one of the organics causes that I want to discuss in, which is the Hirschsprung disease. So, in general, Hirschsprung disease is a developmental disorder of the enteric nervous system. Okay, it can be characterized by the absence of ganglion cell in the submucosal and meningeal plexus. Okay, next. So the pathology in which we can understand the Hirschsprung disease is that from the arrest from the developmental phase, from arrest of neuroblast migration from the proximal to the distal bowel. So it causes absence of neural inhibitions at the part of the bowel. So this will in turn will cause inadequate relaxation of the bowel wall and bowel hypertonicity. And this ultimately will cause intestinal obstruction.
Nice macam ni kan buat.
Okay.
This kan dah makan banyak ni kan? Fresh vegetable dan fruit dah. Konsen ambil dah. Bukan buat macam ni, you send to me mandi lagi, pergi mandi, you hantar mandi.
So the next one is the clinical features of Hirschsprung disease. It can be child can be presented with a distended abdomen, history of failure to pass meconium in the first 48 hours of their life, bilious vomiting, feeding intolerance, and if the child is an older children, they can have a history of chronic constipation. And then the child probably have a problem of failure to drive, enterocolitis such as including diarrhea, abdominal tenderness, sepsis, bowel obstruction, probable large fecal mass in left lower abdomen, and protracted. There could be explosive discharge of foul, smelling, feces with gas. So, bear in mind this is the clinical features for Hirschsprung disease. Okay, next for investigation. So, for Hirschsprung disease, a few investigations that we can do for a child with this problem. It can include rectal suction biopsy, which has a large number of hypertrophic nerve bundle that stain positively for acetylcholinesterase with an absence of ganglion cell. So next one is anorectal manometry, in which we can measure, we can identify the internal anal sphincter fails to relax in response to rectal distension. And another investigation that we can do is barium enema, in which we can see that there are abrupt narrow transition zone between normal dilated proximal column and a smaller caliber to distal to the end aganglionic segment. Okay, next. So that's the investigation. And then the treatment. So for children with Hirschsprung disease, the definitive treatment is surgery, of course. It can be temporary stoma, or it can be another procedure called primary pull-through procedure. So primary pull-through procedure is actually the removal of the entire ganglionic column, in which the column that doesn't have any inhibitions. Then we station the normal end of the proximal column to the rectum. So you guys can have a look at the primary pull-through procedure in YouTube. Okay, next one. So okay, so this is basically the figures I attached to compare between the functional and Hirschsprung disease. You guys can have a look at it after this. Okay, next. Okay, so to the gist of our discussion today, which is the approach to chronic constipations. So next one. So it comprises, as we know, it is comprised of history taking, physical examination, investigation, and so on. So for the first part, which is the history taking, so one thing that we have to take note of the child is about the passing of the meconium. Any delete of passage of meconium can suggest the child could have Hirschsprung disease. And then the next thing we want to know is the onset. Okay, so was the constipation present from birth or early infancy? So if it is, then it is more likely to be an organic cause, which could be Hirschsprung disease. And then was there a preceding change in diet? Was the onset around the time of toilet training or around precipitating events? Were there problems with toilet training, such as the child has resistance or fear or late normacy of toilet training? So all of these points can suggest functional constipation. Okay, next. All right. So the next thing that we want to ask is about their stool quality and appearance. So we can ask about the experience of defecations. So is it painful? And if it is painful, then it can suggest functional constipation. Hard stool. Does the stool form pellets in the diapers or toilet? Does it clog the toilet? Also can support the of functional constipation. And then is there blood on the stool? If there is, then we can suspect that there might be an fissures involved. And if the child is toilet trained or accidents in the underwear, soiling of the underwear, so this point can indicate fecal incontinence due to functional constipation and without and leading to fecal infection. Okay, next. Okay, another vital part of the history is that we need to ask about the diet. Okay, so we need to ask parents, okay, given the sources of fibers and the fluids adequate, because low fluid intake can occasionally contribute to constipation, or if there is any changes in their diet, which can suggest functional constipation, possibly due to cow's milk protein intolerance. And then the other part is that we can ask also, are there already underlying medical problems or congenital anomalies, any abnormal growth or developmental delay? So at this part, we can consider neurogenic causes of the constipation. So some causes of constipation, some congenital syndrome are associated with HRA, such as Down syndrome. Another point is that it could be congenital malformation, such as kidney and urinary anomalies, can also raise concern for anorectal, sacral, and spinal abnormalities, which can interfere with defecation. So all of this point we should consider to investigate to know what kind of constipation we are dealing with. Okay, next part, I will be talking about the physical examination. So once we identify the necessary history, then we ought to do physical examination. So for the first part, we need to do the general examination. So the child can be thin build, has failure to try features, any sign of nutritional deficiencies, dysmorphism, and then fever, dehydrated, retentive posture, and then lower limb abnormalities, heterogeneous or atrophy, which can suggest neurologic problem. Next one. Okay, so the next one is we need to see if the child have an abdominal distension. Abdominal distension, palpable stool mass or mass in suprapubic area. So all of this are consistent with constipation that can cause that can identify this sign will help us to know what kind of constipation. Apart from that, we need to also inspect or check the cutaneous changes in the lumbosacral area, whether they are dimple, hair tuft, any lipoma or deviation of the gluteal cleft. So all these are just spinal dysraphism. So disability is actually a spectrum that involves neurological problem of the child, any neurological problem that the child may experience. And then there's a sign of the child has a soil underwear. You can suggest that in the presence of rectal stool infection. So from the stool infection, it will suggest overflow incontinence and functional constipation. Okay. And next one is absence of anal weak or cremasseous reflex and decreased lower extremity tone or strength, which is suggests neurologic dysfunction. Anal fissures or scarring from the consequence of functional constipation. And also if the anus is anteriorly displaced or there are perianal fistula, which mean that she may have anorectal anomaly. Okay, next. So that are the among the physical examination that we need to pay attention to. And the next one is investigations. So the general investigation that we can do for blood, for example, we can do thyroid function test, in which we need to have a look if the patient has hypothyroidism, and then any electrolytes test that we can do with patients as CRP. And then for imaging, we can do abdominal radiograph, barium enema, and spiral radiograph. all of this investigation that we do is the aim is to prove and to exclude our differential diagnosis. And the last one is biopsy, which I have mentioned previously in the analysis, where we can see where we can do biopsy. Okay, the last one for the approach of the chronic constipation. Next slide. Okay, so in generally the management for chronic constipation, it comprises of the toilet training and avoid voluntary withholding. So what we can do, what the parents or caregiver can do, like what I mentioned before, is that for example, after we set a regular toilet sitting for the child, so that they will have their own time, their own habits, so they can pass their so they can defecate. And then we can include positive reinforcement such as reward if they are adherents to this habit. And the next one is to evacuate overload of rectum. So what we can give, we can give lactulose, polyethylene glycol, or bisacodyl. So it depends on what patients need. It can be gradually tapered off later on. And the third one is dietary intervention, in which we must make sure that the child have a balanced diet, which comprises of whole grain, foods, vegetables, have sufficient to eat. So these all management are important so that the child can overcome their chronic constipation problems. So it all has their own role. Okay. So next. So I think that's a brief approach to chronic constipations. If you have any question, you can ask them. Maybe we can discuss.
Thank you, Abdullah. Okay, Doctor, can I proceed?
Muhammad Azlan.
My name is Muhammad Azlan. Okay. All right, my topic. Okay. Bismillahirrahmanirrahim. My topic is liver failure in children. Okay. The topic of liver failure in children is rather similar as what we learned in internal medicine. However, there are a few differences in terms of how we approach. The differential we need to consider in case of pediatrics. So first and foremost, as we learn, it is divided into acute liver failure and chronic liver failure. So in some extent, the definition are different. Okay, next. Okay, acute liver failure is defined as evidence of acute liver injury with no known of chronic liver disease in the past or current diagnosis. Secondly, it must be supported by biochemical and clinical evidence of severely liver dysfunction, which are first, uncorrected coagulopathy. Okay, uncorrected coagulopathy evident by prothrombin more than 20 seconds or international normalized ratio INR 2 or more, which even after administration of parenteral vitamin K, there is still coagulopathy. Thirdly, there is NO or presence of hepatic encephalopathy. Okay, must be present if the PT more than 15 to 19.9 seconds or INR 1.5 to 1.9. Okay, this is from pediatric protocol. Apart from that, I read from Sunflower is defined as a form of severe liver disease with onset of hepatic encephalopathy within 8 weeks. So there is a cut-off point, within 8 weeks from initial symptom and with exclusion of chronic liver disease. So CLD must be excluded to form a diagnosis ALF. Okay, next. All right. Okay, I mentioned about hepatic encephalopathy, right? So hepatic encephalopathy in newborn is usually due to unconjugated bilirubin. Okay, but in older children, it's caused by hyperammonia. Okay, which is the complication of acute liver failure. Which the presentation, of course, neurological deficit. All right, we go to the causes. So that's the important thing you need to know. Okay, based on Nelson, there are 6 main causes of acute liver failure in childhood.
Kenapa you tak type proper?
Oh, sorry,
You see, tak apalah.
sorry, Doctor. Okay, okay, there are in childhood you need to remember, okay, metabolic causes. Okay, yesterday I asked about metabolic causes in neonatal jaundice, but in acute liver failure, metabolic cause is important. Okay, and then CVS, infection, neoplastic, toxin, immunology. Okay, next. Okay, I will go to the incident. This is from Nelson. Okay, in terms of how frequent it is, you can see metabolic and infection are important cause of acute liver failure. Does it need to be considered? While in older children, iatrogenic and drug intoxicant and infection are major factors. Okay, the rest are rare. Okay, I would like to share a forensic case I read. Okay, there are 4 years old infants died due to PCM overconsumption. It was given by his mother, who believed her child is feverish. So eventually, the child died due to PCM overdose. So you need to consider the drug iatrogenic causes. Okay, next. So I will move on to the first etiology you need to consider is the drug causes. Okay, so the drug that may lead to ALF include paracetamol, which is acetaminophen, hepatotoxic drug, for example, anti-epileptic drug, such as phenytoin, sodium valproate, carbamazepine, lamotrigine. And then need to remember some of antibiotic that hepatotoxic, erythromycin, quinolones, isoniazid, and tetracycline. Okay, so just for management wise, for paracetamol toxicity, okay, when there is ingestion, when the ingestion within 1 hour, so what we give if is activated charcoal. Okay, so what activated charcoal do is it is GI decontaminants. Okay, you need to remember this activated charcoal given to bind with the PCM. So thus it will reduce the absorption in the gut together with gastric lavage. As mentioned by Dr. Alwi, we do gastric lavage to wash out or remove as much as possible if the injection within 1 hour. Okay.
Perhatian kepada semua ketenangan Sultan Ahmad Shah Medical Center, para pesakit dan pelawat sekalian. Waktu salat asar akan masuk dalam tempoh 15 minit daripada sekarang. Marilah kita bersama-sama menunaikan solat di awal waktu kerana Nabi Muhammad SAW pernah ditanya, apakah amalan yang paling terbaik? Lalu baginda menjawab, solat di awal waktunya. Untuk makluman, solat fardu boleh dilaksanakan secara berjemaah dan mengikut SOP yang telah ditetapkan. Adalah dimaklumkan bahawa tiada pelawat dibenarkan untuk melawat pesakit dalam tempoh PPPP. Hanya seorang penjaga dibenarkan untuk menjaga pesakit riwayat pada satu-satu masa. Sekian, terima kasih.
Okay, so we continue. So remember, if the PCM overdose injection within 1 hour, we give activated charcoal and also gastric lavage. However, it's more than 1 hour, or you can just maybe 12 hours, okay, or more than that. So the treatment of choice is we give an acetylcysteine, NAC. Okay, so it's the antidote of acetaminophen that induce the hepatotoxicity. Okay, next. So I will go to metabolic cause, which is important cause in acute liver failure. So for example, first is urea cycle defect. So urea cycle defect. So it's a okay, in our body there are a lot of metabolism. In a second, there are thousands of metabolism occurs. Okay, so inborn error metabolism is generally is due to enzyme deficiency. Okay, so in urea cycle defect, there are enzyme deficient in the urea cycle. So what happened is that the amino acid, our body catabolize the amino acid, but if there is urea cycle defect, there will be abnormal IM. Okay, so it require liver to remove the ammonia into urea, but if there is liver failure, liver enzyme deficiency, it can cause urea's metabolism to be defect. Okay, okay. So how do we investigate is by measuring serum amino acid. Okay, so when there is deficient in the enzyme, the serum amino acid will be elevated. Okay, so one of the management wise is we give dialysis to normalize the urea level in the blood. Okay, apart from that is galactosemia. Galactosemia is the metabolism disorder of the carbohydrate. So the diagnosis is by measure the galactose 1-phosphate uridyl-transferase. So this enzyme is low. Okay, so what happened is that the substrate the substrate which is galactose 1-phosphate will be high. Okay, so what happened is that this substrate will turn into galactiole, and it will deposit into organs just as liver. So it present acute liver failure. Okay, so the treatment wise, we restriction of diet using non-galactosemic foods. Okay, so that's the concept of inborn error metabolism. Okay, next is Wilson disease. Wilson disease, you need to remember, it can cause acute liver failure and also chronic liver failure. Okay, so Wilson disease is rare. Okay, I know everyone know what is Wilson disease is a copper excretion that is impaired. Okay, so how do we excrete the copper is by liver lah. Okay, so there is enzyme deficient in the liver, so it causing the deposition of the copper in the liver, so it can lead to acute liver failure due to the overload, which has cytotoxic effect, oxygen radical to the liver, which eventually cause cirrhosis. Okay. I remember from the time we
Rasa
mentioned.
you all ni menyusahkan diri sendiri. Yang level you all belajar ni level apa tu specialist.
Oh.
You all menyusahkan diri sendiri. I rasa reason is sebab kita orang tak beri you limit time. We are more interested of clinical tau. You dos ni I tak tahu kenapa lah you all nak menyusahkan diri sendiri tau.
Okay.
Apalah, continue lah. I rasa sebab tu salah tau. Nabi you all beri lecture, kita orang beri lecture. Beri pada you all lecture, you buat sampai level specialist di mana sampai level yang you tak perlu tahu. Takkan keluar dari MCQ pun tak keluar. Kita takkan tanya soalan tu pun. Tu jadi susah. You all lah. Tak apalah, continue lah.
Okay.
Lepas tu lama orang dengar pun jadi boring. Sebab dia orang tak boleh pick up benda apa dalam benda tu.
Okay, Dr. Sorry. Okay, just remember Wilson disease is causing acute liver failure due to copper overloads in the liver. Okay, so we investigate via serum copper and ceruloplasmin 24-hour urine copper. Neonatal hemochromatosis is the iron overload. Okay, so it causing liver failure in infant. Okay, so they present with jaundice, coagulopathy, ascites. So how to investigate is serum ferritin is high lah. Okay, lead biopsy because of the extrahepatic cirrhosis. Okay, iron banyak kat other organs, so we do lead biopsy. And okay, next. Okay, this is the.
Nafal ke benda ni?
Oh,
topiknya lah.
Okay, next. Alright, cardiovascular. Okay, you need to rule out CVS because, for example, shock and hypotension can cause hyperperfusion, which induce ischemia and then liver failure.
Mana you punya infection?
Infection yang. Okay, next.
You nak hafal semua benda ni? I belajar about carry information ni masa I buat master, tahu tak?
Oh,
I tak dah belajar masa student pun. I cuma tahu nama je. Continue.
okay. Just for you to know that Budd-Chiari syndrome is liver outlet obstruction. There is obstruction in the hepatic vein. Okay, that leads to congestion and then liver damage. Okay,
Rasa you
next.
duduk dalam rumah lama sangat agaknya you bagus juga you duduk asrama. You boleh jalan-jalan ni semua masa tak banyak sangat membaca. Jadi belajar benda yang tu you tahu benda yang you tahu, benda yang perlu tahu, benda perlu you tahu secara langsung je. Banyak masa kat rumah you baca semua benda. Lepas tu bila buat jadi dopak, jadi MO besok semua cuma lupa. Continue sebab yang ada more important lagi you perlu tahu.
Yeah.
Lagi?
Okay, we go to next. Okay, leukemia can also leads to acute liver failure due to infiltration and as well as lymphoma. Next. Okay, autoimmune hepatitis. Is it Doctor?
Apa benda tu beritahu ha.
Okay, autoimmune hepatitis is due to autoantibodies. Okay, there are two types, 1 and 2. Okay, this we learn in internal medicine. As addressed, we need to investigate by using the autoantibody detection. So next, in type 1, ANA and asthma autoantibodies. Ya, Doktor?
You nak tahu semua benda ni? I pun tak tahu. For information. Proceed.
Okay. Next is the infection.
I can assure you all my specialist pun tak tahu.
Okay. Next, this is autoimmune hepatitis.
Tak payah.
Next
Sebab
Fatul.
usi pun you nak tahu.
Okay, infection. Yeah, infection is important.
Tak ni the first one.
Sorry. Okay, you need to remember.
In 9 minit you tahu. You sepatutnya you seminar 1.5 hours je, bukan 2-3 jam. Oh, you 1.5 hours seseorang kasih dalam 1 hour macam nak habis.
Okay. Alright, you need to consider hepatitis A, B, and E, which can, for B, it can cause chronic liver disease as well, and C. However, for A, is usually resolve itself. Okay. So how do we investigate? Is via virus screening. Okay, you need to remember, hepatitis B can be transmitted, as mentioned by Dr. Nick Ashra. Hepatitis B due to vertical transmission is common in pediatrics. So you must do virus screening. Okay, next, herpes simplex virus is also important. You need to check Epstein-Barr virus, CMV, leptospirosis, and dengue. Also, one of the differential. Okay, go next.
Setakat tu saja. You know, the one is you should explore more detail is the infection. Or yang batu Wilson, you know Wilson disease saya jumpa sekali saja 26 tahun, tahu tak? Buat carry jumpa satu je dan 26 tahun. For information lah. Kalau hemochromatosis tak pernah jumpa pun. Tapi hepatitis berlambat jumpa. Infection hepatitis, leptospirosis semua berlambat jumpa. Itu yang sepatutnya cakap more detail. How lepto cause heart failure, liver failure, how the accessory hepatitis cause liver failure. You nak cakap benda-benda yang rare tu buat apa? Waktu sebab apa itu? You buka Nielsen. Continue.
Alright. So from the history, okay, of course we need to suspect of the jaundice. Okay. Usually, it can cause prolonged jaundice. Okay, what is prolonged jaundice? Jaundice more than 14 days. Okay. Then personal changes. it is a form of hepatic encephalopathy. Okay, you need to know, you need to ask the parent. Parents more helpful for these personality changes. Okay, for example, personal changes, the patient may have intellectual deterioration. Wait. Okay, the children may have intellectual impairment. For example, they may have poor concentration, they have difficulty in thinking, they have shaky hands, so difficulty for handwriting. Okay, for more severe form, hepatoencephalopathy can lead to confusion and coma. Also, it can lead to sleep cycle. Okay. There will be grading. Okay, don't worry. Okay, next, lethargy, because patient in acute liver failure may have refused to feeding. Okay. Okay, and acute liver failure can cause hypoglycemia. Okay, next. Okay. Okay, next. Okay, so you need to ask about the infection history. Okay, ask history of fever, history of vomiting, history of contact, blood transfusion, travelings, and water-based activity based on the differential diagnosis. Okay, beforehand, and then we need to ask the medication given by the parents if the patient have given anti-epileptic, PCM, or antibiotic taken, and you need to ask about past medical history. Okay, it's important because we want to rule out chronicity of the pathology, whether it had acute or chronic. Okay, next. For family history, yeah, autoimmune hepatitis and Wilson disease is a disease of genetic predisposition. You need to ask about birth history. Prematurity are common in prematurity, one of the factors of acute liver failure, but it's in neonate. Okay. Antenatal torch infection, prematurity, you need to ask about the antenatal history of the mother. Okay. If the mother have hepatitis B diagnosed or undiagnosed, torch infection can be present with hepatitis. Okay. Then is growth history. For the current being, okay, ask about any history of poor weight gain or FTT, failure to try. Okay, next. Okay, this is this is from sunflower, which is the feature of liver disease. And then, okay, you can say encephalopathy, jaundice, epistaxis, cholestasis due to fat malabsorption, and then it can present with deficient of vitamin K, fat soluble vitamins, pruritus, pale stool, and dark urine. Patient will come with ascites, hypotonia due to encephalopathy, peripheral neuropathy, and rickets due to vitamin deficiency. Okay, and then the other one is the complication of the liver disease. First is portal hypertension. They may come with upper GI bleeding, varices, esophageal varices, spider nevi, muscle wasting from the malnutrition, bruising, and petechiae. They may present with splenomegaly, apart from hepatomegaly because of the evidence of portal hypertension. Okay, and then hypersplenenism. Hepatorenal failure also presented. Okay, okay, clubbing, and then loss of fat stock, secondary to malnutrition. Okay, next is you can read about clinical features from in the pediatric protocol as well. Okay.
Yeah, tapi this one more important daripada dia tu nak present about galacto, nak present about Wilson. Faham? This one more important. Bukannya tu present pasal Wilson disease. Ini. Continue.
Okay. Next.
Gua tak tahu mana yang penting, mana tak penting.
Okay. I think I have mentioned about hepatic encephalopathy is due to hyperammonia. Okay, in older children. Okay, next. Okay, there are 4 stages. So this is from pediatric protocol. You can grade the extent of the severity based on the symptom. Okay, first symptom, clinical manifestation, and then the sign. How to elicit by flapping tremor. Okay, and then at times we can grade using EEG changes at time, right? Electroencephalogram. Okay, there are 4 stages: prodrome, impending, stupor, until it can cause coma. All right, next. Okay, this is assessment, the severity of acute liver failure using child Turcot per class, grade 1, 2, and 3, via clinical and also biochemical. Okay, they present with encephalopathy, ascites, bilirubin, albumin, and prothrombin. Coagulopathy. Okay. So class A, class B, and class C is class C is more severe, more than 10, which is indicate more severe liver disease. Next. Construction apraxia is I don't know about if it is done. Okay, it's basically we ask patient to follow simple command. Okay, next. Investigation. Okay, we do full blood count to check thrombocytopenia. It could be low. Okay, it's due to low production or overconsumption, and we can rule out high white blood cell. It could be due to stress or infection, and then low white cell count due to leukemia, aplastic. Okay, coagulation screen is important. Okay, for the diagnostic liver function test, usually is presented with hyperbilirubinemia. Albumin will be low. Aminotransferase high, more than 1,000. ALP, glutamate, and GGP, GGT could be a sign of obstruction. Okay. Okay, renal function test, urea can be high or low. Why could be high? Because high urea may indicate dehydration, right? Okay, upper GI bleeding. How about if low? When there is hepatic failure. Okay, we need to check for creatinine because liver failure can lead to hepatorenal syndrome. Okay, serum ammonia, yeah, need to check. We need to know the baseline and monitor the progression. Serum glucose as well. Okay, next. Okay, virus serology to rule out to confirm infectious causes. Okay, virus screening such as hepatitis A, Hep A IgM, Hep B HBs antigen, Hep C viral loads. Okay, autoimmune marker as I mentioned, autoimmune hepatitis, asthma, ANA, and IgG. Serum urine copper for rule out Wilson disease, and we need to do to screen for drug toxicity. Okay, for example, like paracetamol, and then salicylate level. And if there is suspect of sepsis that causing liver failure, we do sepsis workup. Next. For imaging wise, we do ultrasound of abdomen, okay, to rule out ascites. Okay, or we can rule out Budd-Chiari syndrome if there is obstruction of the hepatic vein, and then we can assess the portal hypertension as well. Okay, we do EEG because we want to grade hepatic encephalopathy. If there is presence of hepatic encephalopathy, we can diagnose using EEG. And from the pediatric protocol, it mentioned if patient are comatose, we need to consider intracranial bleed. So that's why we request CT scan of the brain. Okay, next. Okay.
Tak payahlah tu.
Okay, next.
You akan tahu pun.
Okay. So first thing first, we need to resuscitate patient. Okay, fluid therapy. Secondly, it's important for us to know the differential diagnosis of the childhood that I had mentioned previously, where inborn error metabolism not to be taken lightly, but we need to prioritize the toxic infection causes, especially HBV, and then rule out autoimmune causes in childhood as well. By doing so, we can anticipate the complication and also we can avoid it. Lastly, we can consider liver transplant. Okay. From the Alwi mentioned, liver transplant is rare in Malaysia among childhood. Okay. Next. So this general measure, close monitoring close monitoring with a head elevated 20 degree without flexion, because this management of cerebral edema. Do not sedate unless ventilated. I read in palliative protocol HE, we need to ventilate. It need mechanical ventilation, particularly in grade 3 and 4. Frequent neurological observation, vitamin K if prolonged PT, and then we need to give prophylactic H2 antagonist, full septic screen. Next. Liver transplant, I think you can read from palliative protocol. Next.
Berapa panjang ni lagi? Kita 30 minit dah lebih dah. Berapa slide lagi ni?
Dalam 10, doktor.
10 slide. Siapa yang present selepas ni?
Saya Dr. Fadzil.
Ya, topik berapa orang lagi presentation?
4 orang. Saya the last presenter.
You present Yumi dulu. Kalau dia ni baru pakai yang ini.
Okay.
Kalau sampai you rasa di history tu you paling longest sekali tau. Baru 3 presentation dah 1.5 jam dah.
So Assalamualaikum. I am Fatul Hakim. So I will present you about functional abdominal pain. So this is my outline. So
Muhammad apa?
So
Muhammad apa?
Muhammad Fatul Hakim.
Topik apa?
Functional abdominal pain.
Present.
So what is functional abdominal pain? So functional abdominal pain is a non-organic chronic abdominal pain. So as you can see in the chart there, so chronic abdominal pain is defined as long-lasting, intermittent or constant abdominal pain more or equal than 2 months, 2 bulan dan lebih. So organic is disease-based, non-organic is functional. So what is functional or non-organic means? It refers to pain without evidence of anatomic, inflammatory, metabolic or neoplastic abnormalities. So the functional abdominal pain also known as functional GID, which is gastrointestinal disorder, which is combination of chronic or recurrent GI symptom not explained by structure or by chemical abnormality. According to Rome 4, 2006, it can be diagnosed after appropriate medical evaluation. The symptom cannot be attributed to another medical condition. So there is a Rome 4 criteria for functional abdominal pain. It must be at least, the abdominal pain the criteria must be at least for 2 months or at least 4 times per month, and including all of the following: either episodic or continuous abdominal pain that does not occur solely due to physiological event, or sufficient criteria for GI disorder, including IBS, functional dyspepsia, or abdominal migraine. So it also, as I mentioned earlier, it may be diagnosed after appropriate evaluation that the abdominal pain cannot be fully explained by another medical condition. So the epidemiology is a worldwide 13.5%, and it occurs in high school, higher 70%, and then it most commonly occur in female. So what is the pathophysiology of the functional abdominal pain? It is complex and not fully understood. As we know that it involves enteric nervous system, ENS, and central nervous system. The dysregulation of the brain axis, we call this brain axis, can lead to the functional abdominal pain, which is due to the abnormal reaction of the stimuli. So such as physiological stimuli when you eat your meal, or because of the gut distension or hormonal changes, or due to the nauseous stressful stimuli, and also with psychological stressful. And there is second theory due to the visceral hypersensitivity, which is sensitization apparent due to mucosal inflammatory process by infection, allergies, or primary inflammatory diseases. This will decrease the threshold, the pain threshold, and the body perceives the normal stimuli as the pain. So the classification of the FGID, you can divide into four, which is functional dyspepsia, irritable bowel functional dyspepsia, pain or discomfort that is centered in the epigastric region. So it can be characterized by bloating, satiety, retching, or vomiting. While abdominal migraine is characterized by recurrent episode of abdominal pain. But however, the migraine is not prominent in the child. Okay. So the functional dyspepsia at least 4 days per month. So it can include one or more following, such as postprandial fullness, elicitation, epigastric pain, and it is abdominal pain at least 4 days per month. One more of the following. So it is related to deviation and change form of or appearance. So in children constipation, the abdominal pain does not resolve with resolution of the constipation itself. So at least one, which is the paroxysmal episode, intense acute periumbilical mealy or diffuse pain, or episode are separated by week to 2 months. The pain is incapacitating and interfere with normal activities, stereotype, pattern, and symptom in the individual patient. And the fifth, the pain is associated with 2 or more of the following, which is anorexia, nausea, vomiting, headache, photograph, and no. For the functional abdominal pain, at least 4 times, at least 2 months. So of course, it has abdominal which is either intermittent or continuous in nature. So that does not occur solely due to physiological event. And you can diagnose it when there is insufficient criteria for IBS, FD, and abdominal migraine. So you go to the software and see what is the pain itself, the site of the pain, so what is the onset,
dengar lah. Betul. Jika dekat sikit pada Fatul.
Okay.
Tak apa dengar.
Okay. So for any presentation, you must ask about the pain itself. So you must have what is the concept? Okay, is it recurrent, chronic, or you have to ask about the characteristics. Any might be suggestive of any other. It have everything factor. Is it resolved spontaneously? And is it exacerbated by stress? And the timing of the pain itself, it usually 2 hours. So or delay the children from going to school, which you can see here, the hallmark of the functional abdomen is the absence of the children itself. So if there is no red sign, so you don't have to do the further investigation. I will show you what is the red sign. So this is the red flag or the red sign. You have to aware. You must need to do the further investigation if the patient has symptoms, the pain that will start with the constantly persistent, right lower quadrant pain is significant vomiting and unexplained fever. So you can read that you might need to do the further investigation. The other means also for localized tenderness, right up or hepatitis Jones, so you might identify other causes before you diagnose functional abdominal pain. So this also is recommended. So the differential diagnosis that I show here is the organic abdominal pain cause. So you must exclude the organic causes first, and then you can diagnose the functional abdominal pain. So the child comes to you with chronic abdominal pain. You must accept the child have red or warning sign and symptom, and you must do the examination. It's
Siapa nak baca benda ni?
normal, and then you do the normal to for
You all kan bila you buat macam ni, siapa nak baca? You type lah, type yang important things. So, you taruh benda macam tu, expect orang nak baca ke? Type, belajar, bila you type benda tu, you akan ni. Lepas tu bila you type pun, you tahu apa benda you nak baca. Ni baca semua ke? Okay ha. Continue.
So then you have to do the stool of blood test. So it's normal. So you can make an initial of functional abdomen, and there is no need for the investigation. Okay. So patient has functional abdominal pain. There is no need for the investigation. However, you can initiate investigation to reassure the parents as BC, okay, ESR, CRP, culture.
You ingat, ini kan orang nak baca buku tau. Bukan nak baca slide. Nak baca buku tau, nak baca buku. I present beratus-ratus presentation lecture pun tak pernah buat benda macam ni, tahu tak? Because bila you buat slide so orang tu boleh baca the slide, faham tak? Tujuan orang buat slide. Kalau tidak asal buat slide. That's why you do the slide. You do the slide because you want to read the slide. Macam ni dapat buku. Siapa nak baca? I pun tak boleh baca. Warning sign. See table tu 1.6.6. Dia cari balik table tu. Continue lah.
So for the management for this first you have to ensure that this disease is not so serious, so you can eliminate the fear of
macam ni.
unknown,
Nice
and
ke
you
you buat.
can validate symptom were real, but
Dia buat macam ni. Oh, nice, orang nak baca.
so you so you can validate the symptom were real but not dangerous or serious. There is no serious underlying disease, and the child can return to regular activity and school, and you can close monitoring, follow-up and counseling. You can do some lab tests if needed in reassurance. second is psychotherapy. So you can refer psychiatry if there is unidentified psychiatric illness or tendency, such as depression or being bullied, and then you can do many psychotherapy for patients, biofeedback or guided imagery. Guided imagery is like you want to distract the child from the pain, so you give the image. Okay. There is, you can teach the child relaxation technique. And the CBT is cognitive behavior therapy, which is you can manage the pain and functional disability for the short term. And a family therapy, you must include the father and mother to the psychotherapy also. And there is also hypnotherapy. Hypnotherapy is also a way to distract the child from the pain. So the third is dietary. So you must add fiber or supplement to the child's diet. Basically, because you want to flush out uh, any stool in the bowel. So there is also specific elimination such as lactose or fructose. The patient might have lactose intolerant or fructose intolerant. And there is also stated that if the child is bloating, you can give low FODMAP diet, which is fermentable oligosaccharide, disaccharide, monosaccharide, and polyo, because this FODMAP can lead to poor absorption and rapid fermentation. For pharmacotherapy, so pharmacotherapy, you can give SSRI, which the serotonin have effect on GI, which can increase the motility of the gut. So you can give TCA, which have no epinephrine mediated, which is reduction in pain, and it also have anticholinergic effect. So you can give antispasmodic and also peppermint oil or menthol. Peppermint oil is also have antispasmodic effect. For dyspepsia, it because of the pain, abdominal pain center, epigastric region. So you can give proton pump inhibitor or H2 antagonist, which can reduce the acid in the stomach. For the IBS, irritable bowel syndrome, you can give anti-diarrhea or non-stimulative laxative. So the prognosis, FAP improve with time, and most children will be able to grow out of it. So the prognosis is actually good in this child. So is my reference. Thank you.
Oh, only you kali present that one.
Thank you, Fatul. Okay. Chronic liver failure in children, the differential rather similar. So it's defined as next. Next, Fatul. Okay. It's a long-standing. Okay. And then irreversible change in the hepatic structure, and then may end up in an complication like cirrhosis, which leading to premature death. Next. Okay. I think the most common cause of CLF is hepatitis B and C. So based on sunflower. Okay. Next is inborn error metabolism such as Wilson disease. So the most common is the infectious cause, where it induce so this hepatitis virus cause induce continuous inflammation of the liver. So you see, from the healthy liver, it can lead to fibrotic liver due to continuous inflammation. Okay, and then it will lead to extensive scarring, which can block the flow of the blood through the liver and cause liver function to deteriorate over the time. So it called cirrhotic because cirrhosis. This is called and then which may predispose cirrhosis may predispose to liver cancer. For example, hepatitis C, also in hepatitis B. Okay, next. Okay, this other congenital, that one is acquired. Congenital may include biliary atresia. I think I've mentioned in the previous presentation before. Tyrosinemia, untreated galactosemia, alpha-1 antitrypsin deficiency. Okay, I will more focus on biliary atresia. Next. Okay, biliary atresia. I think you need to remember. Okay, biliary atresia is the bile outlet obstruction. Okay, the liver cannot secrete the bile into the duodenum, so eventually the bile reflux into the liver. Okay, so it's causing damage to the hepatocyte. So the gold standard here is diagnosed using HIDA scan. Okay, ultrasound is least sensitive. So by using HIDA scan or other golden standard gold investigation is liver biopsy. So we can confirm biliary atresia. Then we can proceed to Kasai procedure. Kasai procedure as mentioned.
Just know kasai sudahlah. Tak payahlah nak tahu macam mana benda kasai tu.
Okay.
Tak keluar, takkan tanya you dah lah. Apa tu kasai prosedur?
Okay. Alright. Proceed. Okay. In older children, hepatitis B, hepatitis C, as mentioned, is the most common. Okay. Okay. Next. Okay. So here is the pathophysiology of cirrhosis formation in normal in the children, where it present with, for example, obesity, insulin resistance. So these are the risk factors to lead to cirrhosis in chronic liver disease in children. So it can from the non-alcoholic fatty liver to steatohepatitis until fibrous forming cirrhosis. Okay, you need to check the risk factors, obese especially. Okay, next. Okay, so this is picture. So you can see the changes and the physical sign. You see in the first picture, scrotal swelling due to ascites. And then you can see distended abdomen, maybe due to from the ascites, or hepatomegaly. You can palpate hepatomegaly. Okay, if present of portal hypertension, you may palpate the spleen. Okay, you can see the child is malnourished. Okay, thinning extremities. Okay, from the second picture, there is grossly distended abdomen. Okay, it's mentioned there it's due to ascites, hepatomegaly, and there is umbilical hernia.
You ada 7 minit lagi.
Okay, so next. Next, Fatul. Okay, allergic syndrome. It's very rare. Okay, but I've mentioned.
Itu apa? You want us to ask MCQ adjust syndrome ke?
No. Okay, next. I think I've mentioned about allergic syndrome in previous. Okay, imaging. Ultrasound scan is the main investigation to diagnose CLD. So we need to compare the histology. You can see the hepatic vein in the normal below picture is the hepatic vein and portal vein are rather well.
Keluarkan apa tu? You want us to show you dalam dalam dia punya PBL picture atau ultrasound liver punya gambar.
Okay.
You tahu tak yang paling penting ialah apa? history taking. 2 is the physical
Examination.
continue.
Okay. Alright. So just mention there. Okay. So I think go to approach of management. If present of ascites, we need to restrict sodium intake. Okay, limit the fluid and monitor renal function. Input on output chart. Check for spontaneous peritonitis. Okay. Nutritional compromise. We need
Now,
to
why you need to supplement any vitamin?
because there is vitamin for
Why vitamin deficiency?
malnourished patient have
Why the vitamin deficiency? You see,
because
you present what the problem of the liver failure. The patient develop malnutrition, vitamin C deficiency because there's the vitamin A, D, E, K is not available, cannot be made. That is the thing. Vitamin K deficiency result in the easy bleeding.
Yeah.
That is what we want you to tell us. Bukan gambar ultrasound, bukan Alagille syndrome. We want you to tell the more important things. No. What is the if vitamin C, if chronic renal failure, apa dia punya finding dia, kenapa dia finding macam tu, kenapa dia easy bruises, we want to know that, because the liver function is produce what factor 1972 1972, result of that PT prolong. That is the what we want you all to learn, bukan nak belajar pasal Alagille syndrome, bukan nak belajar pasal apa tu Wilson disease. We don't want you to learn. We want you to learn all these basic thing. Because the thing yang come back dalam exam is, okay, we going to ask you kenapa budak tu ada bruises dalam liver failure. That's we will go to ask you. We're not going to ask you apa tu Alagille syndrome. We're not going to ask you unless you doing master student. You're doing master, tau, master yang jadi pakar, you doing master nak jadi pakar. Then we're going to ask you. This is the basic thing important. The thing the more important for you to learn. No. We're not going to ask you how Kasai was done. You just mention Kasai, enough, finish your day. Itu pun if you don't mention Kasai pun, you're not going to fail. No, we're going to operate, finish. More important for us is that you tell us that there is obstructive jaundice. They come, they present with the obstructive jaundice. They come to jaundice, the SB is high, and then that's more important to us. Differential diagnosis of direct bilirubin. Bukan pasal kasar operation. What is important in the biliary atresia is a block of the biliary. The presentation is a what? They come persistent jaundice with high direct bilirubin. The color stool is pale. That is what we want you all to learn. Bukan dah hiding like this. Lepas tu menyusahkan, jadi you benda ni you tak faham pathophysiology, and then jadi boring lah. You tak understand, because we going to ask you what is differential diagnosis of direct bilirubin, high bilirubin. Then you say biliary atresia. Okay. Then what happen? Biliary atresia can cause heart failure because hepatitis, because the bilirubin damage the liver. What the presentation of liver ni? Or they can have jaundice, failure to try, ascites, easy bleeding, easy bleeding. Why they check easy bleeding? Because vitamin liver produce collagen factor. What collagen factor they produce? 10, 7, and 2. That is what we want you to know.
Okay.
Tak payah nak tahu Wilson pun semua. You don't need Wilson. You tak tahu Wilson pun, you're not going to fail. I only see Wilson for 26 years satu kali je. Tapi I see biliary atresia dah dekat berpuluh-puluh dah. Continue.
Okay. Okay, lastly, hepatic encephalopathy. Patient may, okay, as I mentioned, the culprit is hyperammonia. Okay, so hyperammonia can come from the gut. So usually patient with constipation, we need to give lactulose first because we want to we want to reduce we don't want to exacerbate the hepatic encephalopathy, and second, lactulose function by absorbing the ammonia in the blood into GGIT for removal, thus it can reduce the concentration. So make sure the bowel output is enough, at least 3 to 4 per day. It's over retention. Okay, I think that's all.
Okay. Any questions? Any questions? Okay, finish.
Thank you, Doctor.
Thank you, Doctor.
Thank you, Doctor.
Thank you, Doctor.